Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with placement of fiducial markers, single or multiple. The bronchial biopsy is performed with biopsy forceps directed at visible bronchial tissue or a visible endobronchial lesion. After inspection of the upper airway and vocal cords, and usually after placement of an endotracheal tube, all of the airways are inspected and the site or sites for the bronchial biopsies are determined. The biopsy forceps is advanced through the suction channel of the bronchoscope into the airways. Bronchial biopsies are obtained from one or more sites and placed in formalin and sent to pathology. The bronchoscope is then withdrawn from the airways and removed from the patient. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with tracheal/bronchial dilation or closed reduction of fracture. The physician performs tracheal/bronchial dilation or closed fracture reduction using a flexible fiber optic or rigid bronchoscope introduced through the nasal or oral cavity. The physician uses the views obtained through the bronchoscope to identify any narrowing or fracture of the trachea or bronchus. The physician introduces a wire through the narrowed or fractured part of the airway and removes the bronchoscope. A series of dilators or stents are passed over the wire to open the airway until sufficient dilation or closed reduction of the stricture or fracture is accomplished. This may be done with or without fluoroscopic guidance. A rigid or flexible bronchoscope is advanced to the stenotic area. A dilation catheter is placed through the bronchoscope into the opening of the focal stenosis and under fluoroscopy is threaded distally to just beyond the focal stenosis. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with balloon occlusion, with assessment of air leak, with administration of occlusive substance, e.g., fibrin glue, if performed. Code 31633 is an add-on code to be used with 31629, in which a needle is passed through a channel in the bronchoscope, into the trachea, main stem, and/or a lobe of the bronchus, and an aspiration biopsy is obtained. Report 31633 for each additional lobe in which this is done. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with removal of foreign body. The physician views the airway using a flexible fiber optic or rigid bronchoscope introduced through the nasal or oral cavity, using local anesthesia of the patient's airway. The physician uses the views obtained through the bronchoscope to locate the foreign body within the airway. The physician passes a snare, basket, or biopsy forceps through a channel in the bronchoscope to grasp the foreign body. The bronchoscope and foreign body are removed. This may be done with or without fluoroscopic guidance. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with placement of bronchial stent, includes tracheal/bronchial dilation as required, initial bronchus. A rigid or flexible bronchoscope is advanced to the stenotic area. A dilation catheter is placed through the bronchoscope into the small opening in the tumor mass and is threaded distally to just beyond the tumor mass under fluoroscopy. The dilating catheter is removed and a guide wire is inserted through the bronchoscope into the now patent trachea. The bronchoscope is removed, leaving the guide wire in place, and the stent catheter is manipulated over the guide wire into the previously stenotic area. The bronchoscope is again inserted and the area is visualized both through the bronchoscope and by fluoroscopy. Two metal markers are taped to the external chest wall under fluoroscopy. The stent is deployed, using both markers for fluoroscopic guides and under direct vision by the physician using the bronchoscope. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, each additional major bronchus stent. The computed tomography scan is re-reviewed to pre-measure and ascertain the size of the stent to be deployed. Proper stent sizing is critical. The stent length should exceed the length of the lesion to some degree to ensure patency. If the stent is too small in diameter, it may migrate. Conversely, if it is too large, it may not open upon deployment or may cause stress on the airway wall. Following removal of the bronchoscope after deploying the first stent, the bronchoscope is inserted into the right main bronchus and is advanced to the obstruction in the right bronchus, where bulky tumor is visualized both through the bronchoscope and by fluoroscopy extending down to where a small opening is seen through a tumor mass into the right main bronchus. A dilation catheter is placed through the bronchoscope into the small opening in the tumor mass and threaded through the tumor mass into the right, lower lobe bronchus under fluoroscopic guidance. Under fluoroscopic guidance, the obstructed endobronchial area is dilated. The dilating catheter is removed and repositioned more proximally in the right main stem where a repeat dilation is performed under fluoroscopy. Next, a guide wire is inserted through the bronchoscope into the now patent right lower lobe. The bronchoscope is removed, leaving the guide wire in place, and the stent catheter is manipulated over the guide wire into the right, lower lobe bronchus. Two metal markers, e.g., paper clips, are taped to the external chest wall under fluoroscopy. The stent is deployed, using both markers for fluoroscopic guides and under direct vision by the physician using the bronchoscope. The two metal markers are repositioned and taped to the external chest wall under fluoroscopy to mark the carina and left main stem bronchus. Care must be taken to ensure overlap between the distal end of the proximal stent and the proximal end of the distal stent.